Okay, this technique is the lumbar rotation gapping manipulation, high velocity, low amplitude thrust. What we're going to be doing in this technique is demonstrating exactly how to perform the maneuver which will allow us to gap one of the lumbar spine joints. Now, of course, most of the literature is telling us these days that we can't be segmentally specific with this technique, but we will try and aim for the L4-5 segment in this case because that's typically one of the joints that we try and gap to manipulate. And this treatment would be used for someone in hypomobility, and this technique is something that we could also use to fit the clinical prediction rule too. The technique will be done with the patient lying on either side. I prefer to use the right side in this case. And note where the table is in this case. The table should be somewhere about mid-thigh height. The patient will be close to the side of the table, laying in a relaxed, comfortable position. The elbow will be lifted up here so that the other arm can interlock through. And this will rest in this position while we get the legs into the position we want. We use a flexion pivot to bring the L4-5 segment into neutral. We'll then have the patient straighten the bottom leg, and the top leg will just rest on there. The legs need to be offset so that we've got a free rotation with the lumbar spine when we go to do the thrust component of the technique. The top hand then will then grab the arm gently and pull up and away into rotation and extension until we feel the L4-5 segment just begin to move. The arm will then interlock back through the patient's arm and then log roll the entire patient close to you so that you can get into a position where you can manipulate without having to actually move the patient too far into rotation. Then crouch down. The patient will be rolled into you so there's a nice, good feeling of solidity between you and the patient. Making sure that you rotate your hips, in this case, to my right so that there's a free position to rotate in that area. You'll then compress the rib cage slightly in this vector to get to the end range of the joint that needs to be thrusted. The forearm, the fleshy part of the forearm here, will be pronated so that it can fit into what I call the slot between the iliac crest and the greater tuberosity or the greater trochanter of the femur. We'll then gently take up the range of motion and we'll hold at that point, which is called a pre-manipulative hold, and then back off. We'll then ask the patient for consent. Do you mind if I actually go ahead and do the technique now? And we'll go back to the end point, and then a quick thrust is performed in this direction. So the thrust is with the bottom hand back into this direction. There may or may not be a click, and then that would indicate that the technique was something we could get up. We would then reassess to see how the patient's symptoms had resolved, and then we would think about the next step from that point.